A very good morning. Today our topic will be dentin hypersensitivity. Holland et al. In the year 1997 defined hypersensitivity as characterized by short, sharp pain arising from exposed dentin in response to stimuli, typically thermal, evaporative, tactile, osmotic, or chemical, and which cannot be ascribed to any other form of dental defect or pathology. There are various factors leading to dentinal hypersensitivity, which is listed below. The first one is the loss of enamel caused by attrition, abrasion, abfraction, or erosion. The other reasons are gingival recession, tooth malposition, denudation of cementum, periodontal disease, periodontal surgery, and some patient habits such as biting nails or tailors who tend to hold their bobby pins in their front incisors. They also experience hypersensitivity. Therapeutic medications can also lead to dentinal hypersensitivity. It has both direct and indirect effect. Some medications affect directly by causing drop in pH and leading to demineralization of the tooth and in turn leading to sensitivity. The indirect effect is some drugs induce hyposalivation. There are drug-induced gastroesophageal reflex disease and also drug-induced vomiting. The gastroesophageal reflex disease, which induces acids produced from the stomach to affect the lingual surfaces of the teeth. So thus we can see more of erosion of enamel on the lingual surfaces of the teeth. Now coming to theories of dentin hypersensitivity, the most common and accepted theory is the hydrodynamic theory, but we will also see into the older theories such as direct innervation theory and odontoblast receptor theory. Under direct innervation theory, it is by the direct mechanical stimulation of exposed nerve endings at the dentino-enamel junction, which is responsible for the dentinal hypersensitivity. The major shortcoming of this theory is that there is insufficient evidence to prove that the outer dentin that is most prone to be sensitive is well innervated or not. The next is the odontoblast receptor theory. In this, the odontoblasts themselves act as a neural receptors and relay the signal to the nerve terminal. The shortcoming of this theory is that there is no evidence to demonstrate synapses between odontoblasts and nerve terminals. The most accepted theory is the hydrodynamic theory given by Brandstorm. In this theory, the hydrodynamic fluid movements occurring across exposed dentin with open tubules are uh, mechanically activate the nerves present at the inner ends of the dentinal tubules or in the outer layers of the pulp. Here is the diagram which represents the nerve direct stimulation theory, hydrodynamic theory, and the odontoblast theory. Coming to clinical features, the most common feature is the pain. The intensity of pain varies from mild discomfort to severe sensitivity. It is usually rapid in onset, sharp in character, and is of short duration. There are external stimuli which elicit the expression of these conditions. They are thermal stimuli such as hot or cold beverages by blowing a cold blast of air. Under osmotic stimuli, it can be caused by sweet food. Under acidic stimuli, the citrus fruits such as lemon, and then acidic beverages such as Pepsi, Coca-Cola, and certain medicines. Under mechanical stimuli, it could also be due to the toothbrushing and also by dental instruments. The most commonly involved teeth are the buccal surfaces of premolars and facial surfaces of the incisors. Other devices which are used to assess dentin hypersensitivity or root dentin sensitivity in the clinical setting given will be discussed, which is given by Gillen et al. They are the constant pressure probe by Apple, then scaling procedures, single tufted brush, chemical stimuli, electrical stimulation, dental pulp stethoscope, air thermal system, air jet stimulator. The differential diagnosis for dentin hypersensitivity will be dental caries, cracked tooth syndrome, traumatized teeth or chipped teeth, pulpitis, bruxism, post-bleaching sensitivity, post-operative sensitivity. The management could be a thorough patient history and clinical examination. Diagnosis is confirmed by using a jet of air or by using a diagnostic probe on dentin in a mesiodistal direction in the area where the patient complains of pain. Clinically, it can be managed by instructing by removing the etiological factors and certain habits which leads to hypersensitivity, such as teaching a proper brushing technique for patients, advising them to maintain proper oral hygiene, to remove the premature contacts and treat for gingival recession, and also identify endogenous and exogenous acids and treat accordingly. Patients are also educated on dietary habits. For example, if citrus fruits or juice such as lemon are taken, uh, they are advised to not brush immediately and to give an half an hour time so that the pH returns to normal. Proper toothbrushing technique and have to be advised and practiced, and also to achieve plaque control. There are various treatment modalities. They are by desensitizing the nerve, by using potassium nitrate paste, by occluding the dentinal tubules by using salts or ions such as 0.4% stannous fluoride, 2% sodium fluoride, potassium oxalate, strontium chloride, and calcium carbonate. By the mechanism of protein precipitates, the pastes used are CPP, ACP, silver nitrate, glutaraldehyde, zinc chloride. And by the method of dentin adhesives, they are dentin bonding agents, composites, glass ionomers. In certain severe cases, crowns can be placed, and also in gingival recession cases, periodontal grafting can be done. And to occlude the retinal tubules, in certain cases, laces can also be used. The, the first thing paste that we saw in desensitizing the dentin is the potassium nitrate. It has been proved to be effective in controlling post-bleach sensitive by employing it as an in-office 10 to 30 minutes therapeutic gel application before and after the bleaching procedures. Fluorides act by precipitating calcium fluoride crystals inside the dentinal tubules. They are available in the form of 2% sodium fluoride and 0.4% stannous fluoride. Potassium oxalate acts by forming calcium oxalate crystals inside the dentinal tubules, whereas casein, which is a milk protein, has been used to develop casein phosphopeptide that gets attached to amorphous calcium phosphate. This CPP-ACP complex in enamel remineralization helps in early enamel remineralization in white spot lesions. They also have shown to have potential to prevent and treat dentin hypersensitivity. Under the dental adhesives, primer of the original Bluma adhesive system can be used, and then glutaraldehyde have also shown positive results. To conclude, to identify the dentin hypersensitivity, a thorough clinical history and the etiological factors is mandatory. And to manage, there are several modalities as we have seen, which can be employed, such as including specific dentrifiers, lasers, irradiation, dental adhesives, antibacterial agents, aldehydes, fluoride rinsers, fluoride varnishes, CPP, ACPP, potassium nitrate, and oxalates. So, above all, in the end, to educate the patient education is very important to remove certain habits and to have an effective treatment for